Yes, I think it's a very important point, and I made it in my presentation. Now, in order to obtain the results, we need a number of aspects to be doable or fulfilled. A, you have to make a diagnosis of Philadelphia positive ALL at diagnosis. We say more or less in a 1 week steroid pre-phase that we have in our protocol. In that window, where patient gets steroid, then we test. We do it centrally for all patients enrolled in protocol, as in other European countries. So you have to make an early diagnosis. B, you need to have a TKI available. Our study was designed now ponatinib, but at least one TKI you should be in a position of giving it. Third, we should identify the genetic landscape at diagnosis, because what I didn't mention earlier, but I'll say it now, we report in the first study, and it's confirmed in the updated Journal of Clinical Oncology, that you have a special genetic profile at diagnosis, that is the so-called Icarus Plus. These patients do less well. These patients probably need to be transplanted. But to do that, you need laboratories who are adequately equipped to do all this. So that's another further complication of all this. Then you need to do MRD well. And MRD well, why am I saying this? Because we think that you should do it by molecular analysis, quantitative PCR. That's a standard in Europe. And that, again, is not widely available. Then, Blinatumomab has increased dramatically responses in the sense that you can obtain an MRD negativity with dasatinib and steroids and ponatinib and steroids, not with imatinib and steroids. But if you don't give Blina, then you have to give chemotherapy. If you give Blina, we're up to 60% of molecular responses at the primary endpoint after 2 cycles, and this increases further after further cycles of Blina, going up to 70–80%. Blina is not approved. Let's say it's not approved for MRD negative patients, because we gave it after induction to all patients, even the better responders. They all got it, and they responded. And this is not approved. You can't give Blina under, let's say, the rules in MRD negative patients. In fact, I may add that even if you're MRD positive, in many parts of the world, it's not approved. So this means that the Blina is not available. It may mean that in some parts of the world you can buy it, the patient can buy it out of pocket. That opens another very serious matter. Is it fair that some patient can get or not? The answer is obviously no. I mean, I come from a country where it's a national health system, and we're in the UK too, and it's the same here, luckily. So all patients, if a drug is approved, are entitled to get it, whether black or white, rich or poor. That is very important. Other parts of the world, you can buy it if you're rich. Is this fair? I would have many doubts on that. So it's a very complicated issue, and this is going to be the challenge. So the ideal world is a patient can enter a clinical study where you get all this. You may get it, it depends on the studies ongoing. If it's not in a clinical study, this is really not doable today. Maybe in the future, but today this is not possible. And this is a pity, because the change is enormous. I mean, rather than giving a systemic chemo transplant, you can do it with a targeted treatment, 2nd or 3rd generation TKI, plus immunotherapy, which now is an infusion, continuous infusion pump. In the future, Blina will be sub-Q. It means you're going to have a pill and a sub-Q formulation. So things are changing. It'll take a bit of time until it's available to most patients, but the future is set there. So I finish my talk to say in the ideal world and the real life. And we have to keep this in mind, because most of the world, unfortunately, falls under the real life, and that is the problem. Just to give you one final example, many elderly patients are not even tested for the BCR-ABLs. And if you have a 70, 75, 80, 85, you have an ALL, why should people think it's a death sentence? It's not. If you're Philadelphia, you can live. We have practical examples of patients living a long time. The last one was a lady who was diagnosed on her 70th birthday, and luckily she was a Philadelphian, luckily we gave her TKIs. She died recently, she turned 90. So that makes a big difference.